So we now have Padma. Would you want to present first? So Dr. Padma will be speaking on one of the most interesting and challenging topics: persistent uveitic macular edema. What to do?
Thank you, Dr. Rima, for the invitation. Very good morning to all of you. So, uveitic macular edema, what do we do when it's persistent? It's not moving. Slides are not moving. I do not have any financial disclosures. Macular edema is macular thickening due to abnormal leakage and accumulation of fluid in the macular area owing to the breakdown of outer or inner blood retinal barrier, leading to increased permeability of the retinal pigment epithelium and increased retinal vasculature. It causes serious visual impairment. A patient is considered to have persistent macular edema if the retinal thickness persists after 6 months of treatment. Macular edema affects approximately 30% of the uveitic patients. It's commonly seen in panuveitis, followed by intermediate and other uveitic entities. Coming to the risk factors. So basically, it occurs because of the breakage of the retinal barriers and systemic factors like diabetes, hypertension, chronic smoking, and increased BMI and advanced age are all risk factors. In addition to that, if the patient has inflammatory other lesions like complications such as choroidal neovascular membrane, ERM, following intraocular surgery, these are all the ocular risk factors for the development of macular edema. Coming to the pathophysiology, it occurs due to the loss of equilibrium between water influx and efflux. Increased influx of fluid, breach in the blood retinal barrier with increased intraoncotic pressure causes vasogenic edema. Activation of Muller cells results in decrease in PDGF, increase in VGF, TNF, alpha, interleukin 1 beta, and prostaglandins. The next comes is a decreased efflux of fluid, results in Muller cell dysfunction, and also the reduced aquaporin receptors. So the microglia cells, interleukin 1 and interleukin 6, and CCL2 and CCX3CR1 are activated, causes RPE dysfunction and increased TLR3 and 9 levels. This results in cytotoxic edema. The combination of vasogenic plus cytotoxic edema results in uveitic macular edema. Coming to the type of uveitic macular edema, commonly we see a cystoid macular edema on optical coherence tomography or diffuse macular edema. Or patients can have cystoid macular edema with subretinal fluid appearance. We'll move on to the case examples. So case 1 is a case of a persistent macular edema. Here, 47-year male presented as a case for bilateral retinal vasculitis with recurrent cystoid macular edema on treatment for 2 years. Coming to the treatment history, he was treated with oral azathioprine, then changed to mycophenolate meftil. In addition to that, he also received local posterior subtenons injections and multiple anti-BGF injections. At presentation, he was on mycophenolate meftil, methotrexate. On investigation, his lupus antibody was positive. Other investigations like HLA-B5, QTB, and serum ACE were negative. This is at the time of the presentations. Visual acuity was 618, parts in the right eye, 6:9 in the left eye. Anterior chamber was quiet. The posterior segment shows media haze, and also we can see the macular edema with well-laced retina in both eyes. OCT shows presence of cystoid macular edema with subretinal fluid in the right eye. In the left eye shows intraretinal cystic spaces with subretinal fluid. Here, the patient received anti-VGF, and we continued the systemic immunosuppressive therapy. FFA showed disc hyperfluorescence, diffuse perivascularly, and block fluorescence corresponding to the laser marks in both eyes with late staining. Patient received 3 anti-VGF injections. However, there was persistence of macular edema in both eyes. At this point, patient was on MMF and methotrexate. Because of inadequate response to systemic immunosuppressive therapy, we switched over to systemic rituximab based on the systemic condition. So 1 month post-systemic rituximab therapy, which was given 2 weeks at the gap, we could see the resolving cystic spaces. However, persistence of cystic spaces were present. So we considered, because of the inadequate response to rituximab as well, considered intravitreal Osudex. Osudex showed initial response. However, there was again the recurrence of the macular edema. Then we considered injection adalimumab in this patient. 6 months, adalimumab therapy was going on, but however, there was recurrence of macular edema in both eyes. So we did the tear cytokine analysis using the tear biomarker pathfinder kit. In this, most of the pro-inflammatory cytokines were elevated. In this, IL-6 was also elevated. We decided to go ahead with injection tocilizumab. Patient received tocilizumab, following which we could see the resolving macular edema in the right eye and the resolved one in the left eye. Now the patient is doing well. It's controlled well with tocilizumab. So started off with MMF and methotrexate. Anti-VEGF injections were given, did not respond to systemic rituximab, topped up with Osudex injection, switch over the immunosuppressive to adalimumab, failed to respond, and finally the patient responded to tocilizumab. So this is a battle we had it with this patient. The next case is again a case of a persistent macular edema, a 50-year female, posterior uveitis with recurrent cystoid macular edema. At the presentations, we could see the cystoid macular edema in both eyes and OCT. Investigations were within normal limits. We started the patient on systemic steroids, started showing the partial response, then switched over to Osudex. And within 1 month Osudex, we could see the resolved macular edema in the right eye and persistence of macular edema in the left eye. So here, the patient was started on methotrexate, and the systemic doses also was increased to 20 milligram. Again, left eye showed macular edema. This is 3 months post-methotrexate therapy. So then, since it did not respond, we added biologics like adalimumab with methotrexate, and we could see the response to biologics. However, that didn't last long. The patient presented with recurrence of macular edema, again in the left eye, following 3 months of adalimumab therapy. So then switched over to immunosuppressive and cyclosporine by the dermatologist. However, the patient did not respond to this treatment as well. Then we started the patient on tocilizumab with MMF. This was in October 2024, it's monthly infusion. Then November, we started seeing the response, and there's resolution of the macular edema, and the patient is doing well with tocilizumab. Did the TR cytokines. Following, this is the pre-treatment tocilizumab and the post-treatment, we could see the decreasing in the inflammatory parameters like MMP9 and ICAM were decreased compared to the pre-treatment value. Next comes the third case. It's a case of a persistent macular edema, defective vision for 3 months. He was treated with anti-TB drugs and oral steroids for retinal vasculitis secondary to presumed ocular TB. He's a strong steroid responder. He was on systemic immunosuppressive therapy with methotrexate 25 milligram per week. Lens, he had a posterior subcapsular cataract. Because of his, the media was hazy in the right eye. The left eye was PCIOL, lasered retina, and we could see the medullated nerve fiber in the left eye with macular edema in both eyes. OCT shows lamellar hole with intraretinal cystic spaces. The left eye shows the presence of intraretinal cystic spaces. Since the patient is steroid responder already on methotrexate, we did try topical interferon alpha 2B, which we have published earlier. Based on a prior experience, we used topical interferon therapy. Within 6 weeks, we could see the resolving edema in the left eye. Coming to the treatment algorithm for the macular edema associated with non-infectious uveitis, bilateral, if it is chronic, first line is corticosteroid therapy. That is, the corticosteroid is more than 0.2 milligram per kg body weight. The second line, if they don't respond, we add a systemic immunosuppressive therapy like MMF, azathioprine, and methotrexate, which we have tried in most of our patients, what we have presented. The third line is anti-TNF, and fourth line is other biologic therapy. In case of unilateral recurrence, possibility of adding intraarterial slow-release dexamethasone implant can be given by changing the immunosuppressive agent. Whenever you see a patient with uveitic macular edema, we divide whether it's secondary to infections or immune-mediated or neoplastic uveitis. If it's infections and neoplastic, we treat the underlying cause to control the inflammation. If it's non-infectious, in addition to control the inflammations, we also decide the macular edema is unilateral or bilateral. If it's unilateral, mild or moderate, we can give periocular steroid injections. Moderate or severe also can be treated with that. If the patient does not respond, then we try systemic immunosuppressive therapy. If they show recurrence, we switch over to immunosuppressive therapy. If it's bilateral, start with steroids or intravitreal dexamethasone implant. The second line we add, that is immunosuppressive therapy. If they fail, then systemic immunosuppressive therapy. The fourth line, interferons. So we have used in most of our patients with all the drugs. If they fail, if they show attraction, then pars plana vitrectomy plays a role. Coming to the topical therapy, topical NSAIDs, topical corticosteroids, topical interferon alpha can be used. And especially in the topical steroids, diphenhydramine has a role. It has a posterior segment penetrations in controlling the macular edema. Local therapy can be in the form of steroids, anti-VEGF, or adalimumab, or we can give suprachoroidal steroid injection as well. Systemic, we have discussed already. Start with steroids, immunosuppressives, biologics. These are my acknowledgements. Thank you for your attention.